Go ahead.
Thanks, Karen. Thanks, Karen. So welcome. Today is Wednesday, November 15th, and this is the Rule Advisory Committee meeting for the update to our Well Women's Services Rule. My name is Brooke Hall, and I am a policy analyst for the division, and I'll be leading the RAC today. And also joining me is Karen Winkle, and she will be recording today's call, and she'll also she'll be supporting me during the meeting. So just some housekeeping stuff before we get started. Please keep yourself on mute unless you are speaking. If you have a question or a comment, feel free to raise your hand and Karen or I will call on you. If you do have a comment, please introduce yourself and the organization or your affiliation so that everyone on the call knows who's speaking. And if you want to be on camera, that's perfectly fine. I'd love to see faces. So if you have the ability when you're speaking, that would be great. There will be time at the end of the RAC for people on the call who are not members of the RAC to provide public comment. I believe the agenda has that at approximately 2:45. And as mentioned earlier in the call, there was meeting materials sent out on November 8th. That included today's agenda, kind of a background document, which just details the history of the underlying legislation, as well as the history of the rule set and the WPSI and HRSA guidelines, and a draft of the rule. So if you did not get those documents, can you please put your email in the chat, and Karen is going to send those back out to the group. Any questions before we get started? All right. Hearing none, let's move on to introductions. I will start with the RAC members, and I'm going to go in alphabetical order. So Amy?
Hi, I'm Amy Cantor. I think I'm here representing Oregon Health and Science University. I'm an associate professor of medical informatics and clinical epidemiology. Just some relevant background information. I'm a family physician. My practice is at the Center for Women's Health. I've also been on faculty at the Evidence-Based Practice Center. And mostly conduct systematic reviews on behalf of federal and non-federal agencies, including the USPSTF, the WPSI, and the NIH, in addition to the Patient-Centered Outcomes Research Institute. But my role here today, just relevant disclosures, is that I'm on the evidence review team for the WPSI. I also serve as an advisory panel member for the WPSI, separate from my job at OHSU. I'm the medical director of the Health Evidence Review Commission for OHA. So just to kind of let you know the various hats, and if I can be a resource from any of those perspectives, happy to be here today. So thank you.
Thank you, Amy. Okay, next we have Antoinette.
Hello, good afternoon. My name is Antoinette Uwachi, and I'm the Senior Regulatory Affairs Specialist for Cambia Health Solutions. Thank you.
Thank you, Antoinette. And Jennifer.
Finding that unmute button. Sorry, I'm Jen Baker. I am the Director of Government Affairs for the Pacific Northwest for Cigna Healthcare and Express Scripts.
Thanks, Jennifer. And Jill? Let's see, is Jill Peterson on the call, or anybody from Columbia Benefit Solutions? Great, moving on, Kimberly.
Hi, I'm Kimberly Haas. I'm with Moda Health Plan. I work with clinical editing and reimbursement payment and correct coding. And so, yeah, I was asked by our regulatory folks to join with this call today. Thanks.
Thanks, Kimberly. Merlene?
Hi, my name is Merlene Converse, and I'm a Senior Regulatory Consultant with Kaiser Permanente.
Thanks, Merlene. And I don't see Rick Blackwell on the call, but is there somebody representing Pacific Source? Or am I missing Rick? All right, Scott White.
Hi, good afternoon. My name is Scott White. I'm the Director of Regulatory Affairs for Moda Health. Pleasure to be here. Thank you.
Thanks, Scott. And Tara. Tara Harrison or anybody from Providence?
Hi, Tara Harrison is not able to be here today, but I am Bo Wright, the policy analyst with Providence, and I'll be representing her today.
Thanks, Bo. Is there anybody that I missed? All right, hearing none. And is there any DFR staff on the phone who'd like to introduce themselves?
Sure. Turn this on. Good afternoon. I'm Lisa Emerson. I'm a senior policy advisor with the division. Glad to be here.
Thanks, Lisa. Anybody else? Karen, I mentioned you, but you didn't get to do an introduction. So do you want to introduce yourself?
Sure. Karen Winkle, and I'm the rules coordinator for the division.
Thanks, Karen. And since Karen has the agenda up, we'll just do a quick review of what we have on the agenda today. We've already done introductions. We'll just do a brief overview of the meeting and purpose. We'll review the background information that was provided to you via email, review the draft rule, have some time for questions and or comments. And additionally, I probably right there at 2:30, if we have time, we'll discuss the questions on the statement of need and fiscal impact, which is a part of the rulemaking process. And then at 2:45-ish, we'll have time for some public comment, and then we'll also discuss next steps. Does anybody have any questions or comments before we get started? All right, hearing none, I'll just go over the purpose of today's meeting really briefly. So the purpose is to modify and update our rule on well women's services, and that could be found at OAR 836-035, I'm sorry, -053-0435. And we're updating these because the Health Resources and Services Administration, or HRSA, and the Women's Preventative Services Initiative, or WPSI, because I will stumble over that if I say it the whole time, updated their guidelines recently. I believe the most recent update was in 2023. And our aim is to ensure that the rule accurately reflects the latest guidelines in preventative services, screenings, and counseling for well women care without cost sharing. Karen, on the screen, there is a background document which just goes over the background for the rule, including the underlying legislation and some of the the timeline for the HRSA and the WPSI recommendations. And this was sent out to you, but I'll go over it very briefly. So House Bill 3391, also known as the Reproductive Health Equity Act, or REA, was passed in 2017, and the legislation was designed to expand access to reproductive health services, and that included well women's services. And that underlying bill did require DCBS to develop rules for well women care in alignment with guidelines set forth by the Health Resources and Services Administration. So we underwent that rulemaking in 2019 and developed the initial rule, which was implemented January 1st, 2019, and it did point to the 2017 guidelines from HRSA. So that is what is currently in our rule. It points to the 2017 Women's Preventative Services Initiative guidelines, which were signed off on by the Health Resources and Services Administration. And then just a brief overview of the recommendations. So In 2011, the Institute of Medicine was commissioned by HRSA to develop recommendations for women's preventative services. Their initial report identified areas for women's health that required preventative services, including well women's visits, and those were incorporated into those initial HRSA guidelines. The HRSA did adopt those recommendations, which became a part of the initial women's preventative services guidelines. And those guidelines required most health plans to cover well women's services without copayments, deductibles, or coinsurance. And then in 2016, the Women's Preventative Services Initiative was established through funding from HRSA with the objective to continuously review and update recommendations so that they were best practices and were the most recent guidelines from the WPSI. Those initial guidelines were developed in 2016, and there was a first update in 2017. I believe our rule currently incorporates those first updated WPSI recommendations, which came out in 2017. And the WPSI updates the recommendations on an annual basis, and each annual update has been subsequently adopted by HRSA. So currently, the WPSI has updated their recommendations, and that includes an updated framework and well women's chart, which includes the array of services that should be covered in a well women's visit. And those guidelines, as well as the well women's chart, was formally endorsed by HRSA in 2022. And again, that's why we're here today, because our current rule points to outdated recommendations, and we're really looking to update our rule to point to the most recent recommendations and include that well women chart in the rule, because it is a very comprehensive and clear illustration of what should be included in well women's services. And I see Amy has a comment. It says, the Well Women Preventative Chart is updated annually. Individual preventative guidelines by the WPSA and approved by HRSA are updated every 5 years on a rolling basis. Thank you. I appreciate that. I was a little confused about that, so I definitely appreciate the clarification. So any questions or comments about the background or why we're here today? Kimberly.
So as I was trying to listen carefully, it sounds to me like HRSA basically says anything that the WPSI recommends is covered in HRSA. So it's like an umbrella thing. Am I understanding that correctly?
So the Women's Preventative Services Initiative develops the recommendations and the guidelines, and then those are reviewed by the Health Resources and Services Association, and they are once they're reviewed, the HRSA signs off on them. So essentially says, yes, these should be a part of well women's services guidelines. And Amy, correct me on that if I'm wrong.
Yeah, that's correct. So the WPSI reviews the evidence summary, and then that moves forward through a multidisciplinary panel and is approved to send off to HRSA, who has to approve it, and then that subsequently informs coverage under the ACA. So anything that is approved by HRSA as and kind of endorsed by the WPSI has to go through a formal process and federal review, and then becomes coverage under the ACA as a preventive service.
Okay, so it's not automatically adopted in the ACA, but I thought that you indicated that the REA Act includes both of these items. So even if it's on the WPSI and not on HRSA, it's part of the Oregon Act, just not necessarily part of the National Act.
So yeah, oh, go ahead.
I think it's maybe just a little confusing because all of the WPSI recommendations have been approved by HRSA. So there isn't really a distinction there, even though they're kind of procedurally separate and related. So there's a cooperative agreement between the two. And so the WPSI is kind of the procedural body to review and analyze the evidence and put forth a recommendation, but then that has to be approved and endorsed by HRSA as a formal coverage recommendation that then gets covered under the ACA. So there isn't any real disconnect between any of the WPSI recommendations and what HRSA approves, at least so far.
Okay.
And just for clarification, so RHEA, the Reproductive Health Equity Act, which is an Oregon-specific legislation, it does mandate services that must be covered under RHEA. However, it also has a caveat in it, which says, well, women care prescribed by the Department of Consumer and Business Services by rule consistent with guidelines published by the United States Health Resources and Service Administration. So that language, that's the underlying statute that was used to develop the initial rule set, whereas RHEA, it required us to develop this rule for well women's services consistent with the HRSA guidelines.
Okay. I'm not sure.
And
if this is, go ahead.
oh, nothing. I thought you were done. I'm sorry. I had a question. Go ahead. Sorry.
Well, I'm not sure if this is the right time to ask, but I did see some items on this graph here, like the fall prevention, that would not be separately codable. So I'm trying to wrap my head around how offering that item without any cost sharing works when it would be part of like the overall visit, not under a separate procedure code. So we might need to talk about that later rather than right at this moment.
Yeah, Kimberly, that's a great point. And I think when we discuss the rule and the well women's chart, that would be a perfect time to bring that up.
Great.
And I'll make sure to circle back with you when we do discuss that.
All right, I'm done and muting myself again.
Antoinette.
Yeah, hi. So I may be just being a stickler here for language. So up on that bullet point, it says HRSA endorsement of the 2022 updates. So endorsement, does it also mean that they have adopted the WPSI recommendations? I just want to make sure that endorsements, because sometimes endorsement doesn't necessarily mean that we've approved it. You know, we support it, but not necessarily approved it. So I just want to make sure that that's equivalent to HRSA approving the WPSI recommendations and adopting it. Sorry, adopting it.
Thank you for that. That's a good clarification. And yes, they have adopted the 2022 recommendations, including the well women chart.
Okay, and from what I understand, with respect to the ACA preventive services, which we are required to cover if it's also recommended by HRSA. So I'm assuming all of these are all the ACA preventative that should be covered at 0% cost share because they're preventive. So that means for HDHP plans too, right? I just want to make sure that is clear.
That's my understanding. Yes.
Okay. Thank you.
Any additional questions? All right, so hearing none, why don't we move along to reviewing the draft rule? And Karen, do you mind pulling that up? Thank you. So since this is just such a short rule, I thought I would do an overview of all of the changes, and then I will have time for questions at the end. Does that work for everybody?
Mm-hmm. Okay. Fine with me.
All right. So the first change is obviously taking out when the effective date of when insurers will be required to cover the guidelines. Currently, it says effective on or after January 1st, 2024. And Karen, correct me if I'm wrong, this date could change depending on when the rule is finalized. Our current goal is to have the rule posted by the end of December, which would make it effective January 1st, 2024. But that could change depending on how long this rulemaking process is, as well as our current spate of rulemaking, because as Karen will tell you, there are a lot of rulemaking that is happening right now. And most of them are tied to legislation, which has an effective date already in the legislation. This one is not. And so it is the easiest to kind of push to the back burner if something happens.
Right. Yeah, I'm going to say right now it's not going to be effective. I'm not going to be able to get it filed to be effective January 1st, but maybe February 1st is a more realistic effective date.
Okay. So just as a FYI to the RAC, that date will likely change, but again, it is based on when this rule will be finalized and posted. The second change was inputting the language, removing the language, adding language without cost sharing right there after provide coverage. We also removed the language all of the and added the word comprehensive instead. And then again, we changed the date of the published guidance for the Health Resources Administration to pointing to the newly updated guidance as of December 2022. And I believe that is December 2022 is when they adopted the recommendations, these current recommendations for well women care. And Amy, correct me if I'm wrong about that, but that's what I could find in all of my research.
I put a link in the chat also to the HRSA website that has some of these kind of more minute details on dates and other provisions that might be helpful to look at if useful.
Thank you, Amy. We also deleted in number 1, deleted reference to the previous guidance and recommendations and added reference to the Well Women's Care chart and included the website where you can find that chart. And then added this sentence at the end: carriers must ensure that all health benefit plans are in full compliance with these recommendations and that all covered services are provided without cost sharing. And then I neglected to change these statutory references at the bottom because there is an underlying ORS now. And so I will be changing the statutory authority and other implemented to reference the current ORS, which I do have if anybody's interested in what it is. So questions, comments, concerns? Antoinette.
Yeah, just I guess just food for thought here. Also based on working on some of the roles. I don't know whether we want to be that specific and mention, and could you scroll up a little bit? Whoever's sharing this screen, is it Karen or is it you, Brooke? Yeah, if you can scroll up a little bit. I don't know whether we want to specify as of December 2022, just so that if they do change it in 2023, you don't have to go back and change it. So maybe change it to, the most current guidelines or something like that. Just a recommendation.
Antoinette, I would love to do that. However, what I found in previous rulemakings is that if we say current guidelines and don't point to the exact guidelines that we are wanting insurers to hold to, then we're running into problems with our delegation of authority. And so unfortunately, that's why we have to update these rule sets anytime new recommended guidance is put out. Otherwise, I would do that because it would make things much easier.
And I guess same for the link to, yeah, problem is what if, WPSI changes the, yeah, all these other factors,
Yeah.
to
I did
consider.
have,
Yeah.
I did have a question about the, I'll go through my questions and then any other questions that we have. One of them was about the links. So currently it does point to the chart on the WPSI website. My understanding, and Amy has clarified this in the chat, is that these are updated on an annual basis. And so my question is whether or not this chart, the 2023 version, should be included somewhere on our DFR website, and the rules should then point to our DFR website rather than their website, so that we don't get into kind of issues with versions. Do people have thoughts about that?
This is Scott from MODA. I think that's a good idea to not put it in the statute and just have it linked to the DFR website, which can be more easily updated.
This is Merlane from Kaiser, and I also agree.
Okay, so I will make that change. The second question I had was this last sentence that was added. I added it, but now I have questions about whether it's repetitive, which says carriers must ensure that all health benefit plans are in full compliance with these recommendations and that all covered services are provided without cost sharing. I think it may be repetitive because that's already included in the language up above. Do people have thoughts about that?
Well, I think as long as, oh, I'm sorry, I forgot to raise my hand. This
Go
is
ahead,
Antoinette
Antoinette.
again from Cambia Health. As long as those form filing requirements are updated, and I'm assuming this is also the product checklist. Is that what you're referring to? Yeah, as long as those are always updated, I don't think it's necessary to include the verbiage you have above that you just added.
Okay.
And
Any
this is
other
Kimberly.
thoughts? Go ahead.
I would say that, we only need to say the part about without member cost sharing in one spot in this rule, not top and bottom. And as
Thanks,
I recall,
Kimberly.
that lack of member cost sharing comes straight out of the RIA language itself. And that's where it's getting added onto here. Is that accurate?
Yes, that is accurate. It is included as a part of the underlying legislation, I think in section 2, maybe 3. Yeah.
Okay, thank you.
Let's see, it's in HB 3391, it's section 2, subsection 3. All right.
Do we mention that too up front? I thought I saw reference to it again up front. If Karen can scroll up a little bit.
It does.
Right here.
Right there,
Yeah.
under without cost sharing.
Yeah.
That's why I thought
Yes.
this sentence might be repetitive.
Yeah, so it's already there.
And I did, so let's talk about the well women chart. Does anybody have any other comments or questions about the changes to the rule? Okay, so Karen, I think I have, my mouse would work. I have the well women chart on my computer. So if you want to stop sharing, I will share it. And then we can get into some of the questions about billing and CPT codes that was previously brought up. All right, can you all see the chart?
Mm-hmm.
All right, Kimberly, and I believe it was you who had the question about CPT codes, cost sharing.
Yeah, right below diabetes screening, it's about 7 or so items down there. It talks about fall prevention. And that is something that would just be billed under the visit code itself, whether that's a preventive visit or a medical visit. There is no separate procedure code for that. And I haven't, scanned every single item on this list, but when that when that is the case where there's not a procedure code for it, it makes it really complicated, at least in my mind, to try and figure out what code do I recommend to our configuration folks needs to be at zero cost share. Does that mean that the visit itself that might cover other things that are not related to this suddenly becomes no cost share, even though there's like maybe 80% of the visit is for something that would be related to cost sharing kinds of services? I'm confused about how to handle that and what recommendations to give to our configuration team.
So that's a good question. Does anybody have any thoughts about that? So my understanding, and I will need to clarify this, is that if it occurs during a well women's visit and it's related to fall prevention, then it should be covered without cost share. If it's not during the course of a well women's visit, I don't believe, I'm not going to say that. I don't know if it would be no cost share. And if it doesn't happen during the course of a well women's visit and there are other services that are provided that are not either preventative or under REA or well women's services, then those services should include cost share if applicable. I don't know that that answers your question because CPT codes are not my area of expertise, but I can look into it more and get back to you.
Okay.
Does anybody else have thoughts or questions about any of that?
Yeah, this is Amy. So the recommendation for well women preventive visits is that women receive at least one preventive care visit per year and continuing across the lifespan. And these services may be completed. So the services listed on this chart, and to help you understand the bubbles is that that they are either A or B recommendations under the USPSTF or the WPSI. Some are overlapping, and the open bubbles have a different implication, meaning that they're recommended for selected groups. So you sort of have to read the fine print. But these services can be completed at a single visit or as part of a series of visits and can be opportunistic. So, you know, again, I can't speak to the individual coding of like fall prevention as the example, but each of these screening services are covered services under the ACA. If they were to be built separate from the well woman visit, because I think a lot of practicing clinicians realize you can't cover everything in one visit, but if you can't bill it under that well woman care, these can be individually billed when applicable.
Well, they can't be individually billed if there's no procedure code for them. Like for the healthy diet and activity counseling, that might be something that happens when the member is in to see their regular doctor for something other than well women's stuff. Perhaps they've got knee pain issues going on. And those are kind of the conundrums of how to appropriately follow this law when there isn't a procedure code to identify that that's what happened. That is only the piece of what's happening. And then, you know, to try and divide out what gets a cost share and what doesn't is very difficult for the carrier when procedure codes don't exist because it's part of a larger package service that might not be subject to that no cost sharing criteria.
So this is Antoinette from Cambia Health, and to the lady speaking, I'm sorry, I can't see the names. I don't deal with CPT codes. You know, we have a team that does. And I'm just going to use a practical example here. So you have a member that goes and sees like your PCP for their annual well women's visit. and wouldn't we look to the provider to determine how they bill it? So if you're saying that there's no CPT code that exists for like healthy diet or activity counseling, then how would the provider bill that? Is the claim coming in under the overarching preventive care service without a line item for healthy diet and activity counseling or fall prevention?
Yeah, because that's what that comprehensive visit code is meant to cover. And it's easy when they're also coming in, for that well women's visit, and that's being coded. But it's not so easy if they're there for something else, and then we get folks coming in that are auditing us and saying, oh, but they talked about healthy diet and activity, and that's covered under REA. Well, but it wasn't a well women's visit. But we've had some recent conversations that take away a lot of that gray activity, or that ability to separate those things out into different categories. It's complicated it tremendously.
I appreciate that, Kimberly. And I think that some of these are considered covered services under Well Women's, and then some of them are also considered preventive services under the ACA. And so regardless of whether some of these are happening during a Well Women's visit or not, they likely should be covered without cost sharing because they're considered preventative or preventive under the ACA.
I guess I'll just say that I would think that probably 80% or more of the items that are on this checklist do have easy procedure codes that we can configure. Some of them not so much. There's not a code for doing blood pressure screening. There's a code for having a visit, but there's not a code for doing a blood pressure screening. That's and those are the things that get complicated for us. We're already very careful about making sure that the preventive services that have a procedure code attached to them don't have cost sharing. And we've made vigorous efforts to be sure that if we can find a procedure code to identify what's going on, that we have complied with this law. But some of these services that are on here don't have procedure codes, and that's when it gets complicated if you're trying to avoid having any penalties for not following the law.
And Brooke, this is Scott from MODA, and just to piggyback kind of on Kimberly, and Kimberly, let me know if I'm on the right track here, because I too am not a coder. Some of these things, let's just use the healthy eating, or it may not come under the guise of a well women's visit or a preventive visit, right? And so that's when it does matter that there's no code, because it could be for something that normally would have cost share, but it's mentioned in the notes. So these really come back in like market conduct audits, and that's what Kimberly's talking about. It's really difficult to, without a code, to suss that out. We're definitely not debating coverage of A and B listed preventive services. That's known. It's just that piece when they come in outside of those expected parameters and they don't have a code. If that had a code, we could say, oh, anytime that code is billed, that is hitting not only well women's, but it's hitting preventive A and B under USPSTF or HRSA, and we know we cover that from an ACA standpoint. Kimberly, did that line up with what you were saying too? Just want to make sure I wasn't adding things. Okay.
No, you did a great job, and I'm sorry that I wasn't able to phrase it like that to make it clear, but that was awesome restatement. Thanks, Scott.
So let me ask, how are you currently becoming aware of these? Is it happening only during a market conduct exam, or are there other ways that you're aware of these kind of services that don't have CPT codes that maybe should be covered under Well Women's or ACA?
There's always. Oh, go ahead, Kimberly. Sorry.
I was just going to say that I know that we have other folks that work on this all the time. My job has wide responsibilities that don't typically have to do with regulatory compliance, but I did get pulled in about 2 years ago now for a regulatory compliance market conduct audit, and to try and answer some questions with issues that were, or at least questions that were coming up on that audit. And thus my job responsibilities have kind of expanded into this arena over the last 2 years. I would like to advocate that we consider getting somebody that has coding experience that can, possibly spend some more dedicated time at this. But
yeah,
that's how it happened for me.
And Brooke, to answer, it's usually a combination of both, right? We're trying to continually evaluate these services anytime, and and rules like this just lead, oh, great, another opportunity to do that. So we're continually evaluating to ensure that proper coverage and proper cost share are being applied. And that's from a regulatory compliance standpoint, working with configuration, with coding, et cetera. And then also the market conduct, the RIA one is the example where a lot of carriers had concerns and questions about that, well, this didn't seem to line up with what was in statute. So it's typically a combination of both, but I know carriers work to identify all of these and suss these out in advance of any kind of market conduct. That's not where I like to discover things, is in that. That's not where we want to be.
Exactly, yeah. Okay. So I had initially wanted to insert this well women chart into rule because, as I said in the beginning, it's a very good visual representation of what should be considered or covered in a well women's visit. However, if there are problems with the coding, the other option is just to say that anything that occurs during a well women's visit should be covered with no cost share and not include the well women's chart. Do people have thoughts about that?
Well, initially I was, before you made that statement, I wanted some time to take this chart back to my coding people to get their feedback and then get back to you. But yeah, good question about yeah, I don't know how to answer that.
Can I ask a question, Brooke? This is Jen Baker with, if you say okay, so if I go in for my well women's visit and you say everything that happens in that visit has to be covered at no cost share, but something not on this list surfaces, that is, then that is
too
not
broad.
necessarily, I think that's too broad. Yeah. I think, I think
it comes with its own set of issues, which
I have to be
you're rightly pointing out.
Like the REA and the well women's, it's just, if you just gave us a list of codes, then we could cover them and it would be applied consistently by all carriers and it would be much easier. So if you could just do that, that would be great. Okay, thanks.
Easier said than done, Jen.
I know, but I'll be honest with you, that's the feedback. And I know this is kind of a little off topic, but that's the feedback I'm getting on the REA draft bulletin is give us a list of codes, because nobody knows what you're thinking at the DFR, and nobody, because every single carrier was somehow non-compliant with, non-declared expectations by the DFR, it was impossible. There was absolutely no way for any of us to be compliant with your expectations of what was supposed to be covered at no cost share under REA, including, unless you give us a very specific defined list of services that have corresponding diagnosis and procedural codes. I will end my soapbox now. Thank you.
Thanks, Jen. Thanks, Antoinette.
Yeah, I agree with Jen Baker 100%. I think that's why we're all here in the first place too.
Yeah. So since the rules likely won't be effective January 1st, 2024, there's no reason we can't have an additional RAC meeting on this either in December or, if there's not time in December, possibly January. So the other option is to allow you all time to go back to review this chart, to look at the CPT codes, and then possibly, like Antoinette or maybe it was Jen, recommended have somebody who has some expertise in CPT codes come into the next RAC and maybe review these ones where there isn't a specific code or where there are concerns and have a more in-depth conversation about it. What do people think about that?
This is Scott from Moda. I think that's a good idea.
Jen from Cigna, and I agree. Good idea.
And
This is Marlene from
Antoinette?
Tiger. I agree.
All right, hearing general agreement, I think we will make that the plan. I will make a PDF of this Well Women chart and send it out to you all. And how long do you generally need for that review? Is that something that you think that you can have reviewed if there is time for a meeting in December, or would people prefer to have maybe a break, since December is a very busy month with lots of vacations, and possibly have the next RAC meeting in January? I know
I
Karen
I would
would
like
prefer
to know
January.
what Karen would have to say.
Is Karen?
Yes.
Yes. You know, from somebody who does scheduling of meetings, I would say let's move it to January, early January. And then, of course, we've got short session in February. So, yeah, I would say let's do the RAC in January, and then DFR can do our stuff late January. We probably would not schedule a rulemaking hearing in February. So that will push the rulemaking hearing in March. So the earliest we could have these effective then would be April 1st. If
And
that's
that would
acceptable.
mean that the language in the beginning would be effective April 1st,
Yeah.
2024, if that's if it happens that quickly.
Yeah, yeah.
Everybody on board with that plan?
Yes.
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 Yes, and I would just say that, you know, for any non-carrier RAC members who are concerned, like almost all of these services are already covered at no cost share, and this is not like an urgent thing that is brand new to us. We are, you know, most, if not every single carrier that I know across the country covers all of this already. It's just a question of really getting to how do we all apply these services and in a consistent manner so that everyone gets, you know, it's impossible for us to cover something that is in medical notes and not in a code. So, but rest assured, if it's coded and it's put into the system, it is covered at no cost share.
Mhm.
Great
Thanks,
point,
Jen.
Jen. I'll second that. Yeah, we got into some in-depth conversations, but definitely that is a great takeaway because that is what is occurring.
Well said, Jennifer. Thank you.
I'm not just an insurer, I'm also a woman.
All right. Any additional questions or comments? We are a little ahead of schedule here, but I think now I'm going to skip the sniffy questions because we're going to have an additional rulemaking hearing, and it makes sense to do those when we have our last rulemaking hearing rather than now. And so I think that would leave us with some time for public comment. So is there anybody from the public that has a comment that would like to give it now? If so, please raise your hand. Great, hearing none. So next steps would be I will send out an updated draft of the rule with the changes that we talked about today, as well as that PDF of the Well Women's chart. I'll send it all to you today. And then I will also send out a meeting link for a meeting sometime in early January for our second RAC meeting. Anything that I'm missing?
Nope. Thank you so much, Brooke.
Yes,
Great,
thank you.
great
Brooke. I
meeting.
really appreciate it.
Thank you.
All right. Thank you, everybody. And I'll give you half an hour of your time back.
Great.
Have a
Thank
good
you, Brooke.
Have a
afternoon.
good one. Bye.
Bye.
Tara, I see that you joined late. If you want me to just review kind of what we talked about today, I'm happy to do that for you.